Much.
Sorry for the delay.
Good morning, everyone. It's Judith Brown here. Delighted to be with everyone and to be here at our wonderful Trillium. I want to recognize my co-authors, Cathy Thorpe, Bridget Ryan, Rebecca Clark, Celia Hamid Jan, and Amanda Terry. We'd also like to acknowledge the support of the Ontario Ministry of Health to our Inspire program, and the views expressed are those of the authors and do not necessarily reflect those of the ministry. The purpose today is to really share with you our understanding of why family physicians become leaders who are engaged in health system change, and to explore strategies for building family physician leadership capacity in the health system. Family physicians play a pivotal role in the delivery of healthcare, and we need to meaningfully engage them in the health system change, especially the new Ontario health teams. We're certainly going to get an exposure to Ontario health teams this afternoon, but just very quickly, they provide a new way of organizing and delivering care that is more connected to patients in their local communities. And under OHTs, healthcare providers will work as one coordinated team no matter where they provide care. So with that in mind, our methods are a descriptive qualitative study using a sample of 18 primary care leaders from across Ontario who are located in rural, mid-sized, and urban communities north, south, east, and west of Ontario. 10 women, 8 men, average age 52 years. We used individual in-depth interviews with semi-structured interview guide to direct us, and all the interviews were audio recorded and transcribed verbatim. The analysis was iterative, and the data analysis occurred concurrently with the data collection using both independent and team analysis. And we paid attention to reflexivity as well as the trustworthiness and credibility of the data. For the findings, there were two overarching themes: motivators for becoming a leader in primary care, and how to sustain primary care leaders in the co-design of health system change. I'm now going to look at these in more detail with you. In the interest of time, I'm going to ask you to be looking at the quotes, and I'll just highlight portions of them. So motivators for assuming leadership role, there were basically four of them: serving as an advocate for their patients, serving as an advocate for the discipline of family medicine, being recruited to represent a specific sector, and having a committed vision to making significant change. The first one was serving as an advocate for their patients. And they really felt that it was, participants stated, an opportunity to get patients some of the care they deserve. And we're looking at issues of inequity and moving forward on that point. Also, serving as a discipline for family medicine. And how do we get a representative family medicine voice? How do we get relevant input? Also, another quote for serving me as an advocate for the discipline of family medicine: I very much wanted to hear about it some more and be involved to ensure the voice of family doctors is represented in the OHT development. Many were recruited to represent a specific sector. In this quote, I was sitting at a table with a couple of people who said, we need representation from a more rural perspective. At which point I said, oh, okay, I don't know who could do that for you. And they said, well, we think you could. And again, another quote looking at representing a specific sector, the idea that this person was a consensus builder and was a woman. Also having a committed vision to making significant change. And one of our participants talked about their younger staff and how they saw the bigger picture and were committed to bringing about change, and that remaining with the status quo was just not good enough. Also, we looked at issues that help sustain primary care leaders in the co-design of the health system change. This included leadership training, adequate remuneration, and recognizing that volunteerism is not sustainable. Here, people talked about the importance of really having leadership training, and if you look at the end of the quote, there's a real sense that you have to control the interactions, you deliver, you direct. Leadership is really about followership. It's really about bringing out the best in other people. And again, coming with leadership training, there are other opportunities for training, such as through the CMA, OCFP, and the OMA, but you have to have a budget to offer people these opportunities. Adequate remuneration was certainly a major issue. I think leaders should be remunerated. Leaders definitely need to be paid to be in these roles. Some of our engaged leaders are saying, man, oh man, this has got potential, but it takes a lot of time. And the concept of building trust takes time and being recognized for doing that trust building in the community. And I just want to highlight that we really encounter tremendous enthusiasm, commitment, and vision from our participants, but really got the sense that even those are tremendous attributes, volunteerism is not sustainable. And one participant stated, most participants are engaging in these activities and they're not taking time out of their practices necessarily, too costly and too disruptive. So they end up taking away personal time, and this is what actually most people are doing. And again, the idea, just at the end of the quote, is a lot of heavy lifting. We even said this to the government when they kept saying, oh, participation is voluntary. And we kept saying voluntary and volunteering are two very different things. And I think this quote really captures it. If you value and respect a role, and indeed if you look at the evidence, which is going to have these transformation efforts succeed, you need to engage family physicians. In conclusion, becoming a primary care leader, or a leader in primary care, is multifaceted. It's driven by motivators, both intrinsic and extrinsic. Future strategies need to include adequate remuneration and leadership training. The application of these findings have potential to maximize the fulfillment of the quadruple aim. Currently, we're interviewing key stakeholders and family physician leaders about the impact of COVID-19 on the development and implementation of OHTs. And we'll be further exploring and understanding the role of leadership in health system change. Thank you very much. I apologize for rushing through. I really want to keep this on time.
Thank you, Judy. If people have questions, hopefully we can address them after my presentation, which is the last one of the day in this session.
So Cathy, Judy is now the host.
Yeah.
So you have to change that.
Yeah. I just don't know whether I do that or she has to do it. Let me see.
She has to do it.
Okay. Have I got Sarah now as the host, Moira?
Cathy, it's Sarah. I think it's Camilla's turn.
Oh, I apologize. Thank you so much. So is that being automated then? Because I didn't choose her. So let me find Camilla's name. I apologize.
Yeah, you should go to Judy's Judy's machine, and
Yeah.
And then choose Kamila,
Yeah.
and say make Kamila host.
Yeah. Okay, so Kamila, I see you on the screen. That's good news. Sorry for the delay.
No problem.
And can you go from there?
Sure. So I just need to share my screen, I guess.
Just tell you your title. Does the pay for performance access bonus correlate with patients' experiences accessing primary care? New insights from urban Ontario.
Are you able to see my slides?
Perfect, thank you.
Perfect, great.
Yeah.
Thank you very much. So good morning, everybody. Thank you for joining this session. I'm Kamila Premji. I'm a family physician practicing in Ottawa, and I'm also a PhD candidate at Western. And I will be speaking with you today about the controversial topic of pay for performance in healthcare, and specifically the work that has been doing about a family physician financial incentive called the Access Bonus. My wonderful team is listed here, including my PhD supervisor. This work is part of my graduate work. So I'll just give you a quick summary of what I plan to go through today. I'll first talk about the origins of the Access Bonus and where they were developed, talk a bit about pay for performance in healthcare, go into our studies results, and then talk about your thoughts on where we should be going from here, not just with the Access Bonus, but pay for performance in healthcare. I'm hearing some creaking. I'm not sure if that's my mic or somebody else's.
I think I can make a suggestion. I think that Judy Brown needs to turn her mic off. If I look at the participants, I see that Cathy and Judy both have their mics on.
Yeah, I'm going to take her right out.
Okay, great. Thank you very much. So Ontario's primary care reforms. Oh, I'm still hearing the creaking. Is there still a mic on?
Sorry.
So many in this room will remember, oh, still some noise in the background there.
Hi everyone, it's Ron here trying to help out.
I still see Cathy Thorpe's mic on.
Cathy, are you there?
Yeah.
I still see your mic on.
Thank you, Cathy. And I think I'll mute myself.
Okay, great. So many in this room will remember that in the early 2000s, Ontario introduced a suite of primary care reforms. And this was at a time when primary care was really struggling, not just in Ontario, but across Canada. There was a shortage of family physicians and access to primary care was suffering. So around this time, Ontario introduced some fairly aggressive reforms. And among those reforms were some financial incentives for family doctors. And among those incentives was an access-oriented incentive called the Access Bonus. And the way the Access Bonus works is like this. Each practice is eligible for a maximum potential access bonus based on their roster size and their roster characteristics. And this can amount to 18 to 20% of the physician's total base capitation pay. So it represents quite a bit of potential income. The practice is then penalized dollar for dollar the value of each of their enrolled patients' visits to outside clinics like walk-in clinics for services that could have been provided by their usual family practice. And it's important to note that emergency department visits don't count in this negation. And that gets you to a final access bonus payment. It's calculated at the physician level based on each individual physician's roster and then paid into the group account as a lump sum total of each physician's attribution for the group to distribute to the physicians. And it's not a cheap incentive. It's not one of the most expensive primary care reforms that was introduced, but it has cost the province over $1 billion so far. So I just want to take a step back here and reflect on the concept of financial incentives in healthcare. Because when we usually think of financial incentives and why they're usually used in contexts where there's little to no intrinsic motivation to drive the desired behavior or outcome. But it's argued in healthcare that this isn't really necessary since healthcare providers already have a high intrinsic motivation to provide good quality care. And there are concerns about some negatives. There are concerns about unintended negative consequences, especially to patient care, and questions about whether these incentives really work. We do actually see evidence of unintended consequences, and we've also most recently seen evidence of decreased quality of care once you take away incentives. Going back to the access bonus itself, it has been criticized for many reasons as well. Patients have free choice of where they go for their primary care, so they may select to go to a walk-in clinic for reasons of choice or convenience, regardless of the accessibility of their own practice. And then there are physician factors, some of which are incidental, like if you happen to practice in a community where there are few walk-in clinics, and others are factors that physicians can manipulate to their advantage. So the question becomes, is the access bonus actually resulting in good access? So I was fortunate to be a part of this study led by Rick Glazier and Mike Green, examining the access bonus. And when we looked at the access bonus using service utilization as our measure of access, we would say, no, the access bonus is not doing what it should be doing. The physicians who were receiving the highest bonuses were situated in rural communities where there was limited choice besides emergency departments for alternate sources of primary care. They provided the least number of after-hours visits. Their patients had the highest rate of emergency department visits. They made fewer primary care visits, and they were more costly to the system. So next, we wanted to take a look at the access bonus from a different perspective, this time using the patient experience as our measure for access. So we did this using a survey called the Healthcare Experiences Survey, and this is what I'm going to talk to you about today, this work. The Healthcare Experiences Survey is a quarterly survey conducted by the Ministry of Health, and it's a survey of adults, random sample of adults, asking them questions about their experiences with the healthcare system, including primary care. And we can link these survey responses to health administrative databases at ICES, including access bonus information. We wanted in this study to take a deeper dive into the urban context. We knew from the previous study that rurality was a strong driver of access bonus achievement. So we wanted to better understand what exactly was happening in the complicated, competitive urban landscape. Our conceptual hypothesis was that there are multiple factors at the patient level, physician level, and practice level that all come together to create the patient experience of access to primary care. And because we theorized that physicians and practices would organize themselves and their services in ways to maximize their access bonus, we treated the access bonus as a predictor of patient-reported access to primary care. In other words, if your physician is being attributed a high access bonus, their patients should be experiencing good quality access to care. We used 4 indicators taken from the Healthcare Experiences Survey, and those were wait time for care when sick, timeliness of that wait, telephone access. So if you call a clinic, does somebody call you back that day? And after hours access. Are you aware of services after hours at your clinic? And we coded these responses from patients as either favorable or unfavorable. We stratified the urban geography into 3 strata to acknowledge the differences in the delivery of services in various urban communities. So large, medium, and small. We ended up with a quite robust sample of patients linked to physicians and practices. We allocated physicians to different quintiles based on their access bonus achievement. So this was calculated as the maximum potential access bonus, a proportion of the maximum potential access bonus they could have achieved in that year. And quintile 1 was the lowest quintile, and quintile 5 was the highest. We used multi-level modeling, and we conducted multivariate regression analyses to control for various covariates. So into our results. So this is the first of 4 of the access, patient-reported access outcomes, after-hours access. So I'm just going to take a moment here to orient you to this slide. So along the bottom axis, first we see these results are reported by the 3 urban areas we examined, large, medium, and small urban, as well as by the overall sample there on the left. And within each of these geographies, we see the access bonus quintiles from 2 to 5, so from lower to higher. And each of these quintiles was compared to our reference category, which is quintile 1, the lowest access bonus. And each of the blue bars that you see there represents the odds ratio for favorable access as you progress from lower to higher access bonus quintiles. Dark blue bars refer to statistically significant findings, and the error bars you see there represent 95% confidence intervals. So with respect to the findings for after-hours access, we do see some relationships here, especially in the settings of larger urban areas, such that the patients of physicians with higher access bonuses are more likely to report their after-hours access as being favorable. And for this outcome, it was interesting to see that some of these relationships are apparently dose-dependent. That is, they increase or decrease with lower or higher access bonus. So going on to the next outcome, which was wait time for care when sick. Again, here we see some relationships, particularly in the large and medium urban settings, finding positive correlations between the access bonus and patient-reported access. Timeliness of that wait, again, some relationships, fewer than previous, but still some in the large and medium urban settings. Larger confidence intervals due to smaller sample size. This question was added to a later iteration of the survey. And telephone access, similar to these previous findings, some positive relationships in the large and medium urban settings. So a bit puzzling. I mean, similar to the previous study, we do see that there does not seem to be an impact of the access bonus on access in smaller centers, but in the larger centers, we do see some correlations between access bonus and access when, in this case, we're measuring it based on the patient experience. Some possible explanations. So one theory could be that the presence of walk-in clinics in large and medium urban contexts creates competition for providing good access, which might be motivating physicians and practices to deliver services in a way that will encourage patients to choose their practice over a walk-in clinic when they need care in an effort to maximize their bonus. So it'd be very helpful to have some qualitative research done to further drill down into this hypothesis. It could be that in either study, the measures that we use are just telling part of the story, so we may need to evaluate the access bonus using still more measures of access. As a cross-sectional study, we can't be completely sure that the physicians and practices in this study weren't already providing good access before the access bonus was introduced, although we do see a dose response. Which gives us some encouragement that what we might be seeing here may truly be causality. And then there were differences between the two studies. We used a different patient sample, we used a different study period, and we used a different conceptual approach to attributing the access bonus to physicians. So on that note, I'd like to hear your thoughts, if we have time, on where we should be going from here. What should we be doing in Ontario with this access bonus as we move forward? And where should we go with pay for performance? It's an ever-increasing feature of health systems around the world. Where do we see it fitting into the landscape, if at all? And where do we see it fitting into Ontario, if at all? So I'll end there, and hopefully we have time for questions or comments.
We are at time, but I'd ask people to make known their questions for you. We'll start Sarah in a moment, and then I'll try and cut mine short given the technical difficulties at the front, and then people that are still in can ask questions then. So thank you so much.
Great, thank you.
Okay, Sarah, can you share your screen, please? And today you're going to be presenting on integrating primary care workforce planning in the City of Toronto.
Can you see my screen?
I cannot. This I can. There you are. Lovely. Oh, and you're gone again.
Okay, you can see me. Um, okay. So I'm having trouble showing you my screen. Would it help if I try logging on through Zoom itself?
I can see your name, but I cannot see your slides.
You can't see my slides. Okay. And does it help? Let's see.
Excuse me, Kathy. Does Sarah need to be host in order to do that?
I'm not currently the host. Kathy, are you going to make me the host, or do you want me to investigate a different way of connecting?
I do that quickly because it seems like mine is not functioning the way it should. If you give me a suggestion on how I click on your name and it doesn't allow me to say to make you the host. Is anyone there to be able to help me determine how to make Sarah the host right now? I can't seem to get there. I wonder if everybody's on. I'm so sorry.
Cathy, I'm going to send you my presentation. Okay, does that sound like a plan? Cathy?
Hi, Sarah. It's Ron here. I just joined the room to see if you guys need some help.
We're having trouble with getting Sarah the host.
Oh, giving her to share her screen?
Yeah.
Okay. Sarah, do you want to just email it to me, your presentation, and then I'll post it?
Thank
Share
you.
my screen.
Oh, sure. I just sent it to Cathy, but I can send it to you as well.
Yeah, I don't mind everyone hearing my email. Ron at rb33.com. Ron at rb33.com. And then thanks everyone for your patience. We'll get it up in a minute here. Okay. Let me know when you sent it, and then.
It's sent.
Okay, thank you. You're not on Safari, are you?
No, I'm on Chrome.
Okay. Yeah. Okay, so I'm just waiting to receive it. Are we at our last presentation here, Cathy?
No, I'm the third one.
I'm just wondering, Cathy, if we jump to our, or Cathy, you're the last one, I believe.
Do you want to go ahead, Cathy, while we get mine organized?
Yeah. Cathy, or not? Is that you? Oh, that looks like you there, Cathy. Okay, so we'll go with Cathy presenting now, I guess, and then I'll help you out there, Sarah, after.
Okay, sounds good.
Okay. Only thing is we don't hear your voice there, Cathy, at the moment, if you're speaking. Cathy, you're on mute still. So you can unmute, and then we'll. This is the beauty of technology. Okay. Sarah, I got yours, but we'll try and get Cathy going here. Oh.
Okay, can everybody see me and hear me?
Yes, we can hear you.
I went into understanding because I think something funny with so here I am. Strategy, frontline family physicians and healthcare system change. My co-authors include Judith Brown, Bridget Ryan, Rebecca Clark, Sadia Hamid, and Amanda Terry. As Judy pointed out, we need to acknowledge the support of the Ontario Ministry of Health for our program. In terms of our purpose, we wanted to understand the strategies for engaging family physicians and healthcare system change, and to examine the barriers to their meaningful engagement in that change. In terms of background, as healthcare systems continue to undergo change, building the collective voice of primary care is very important. And as the demand for engagement and time increases for physicians, it's important to understand how they can be meaningfully engaged. I will skip this slide on Ontario Health Teams. In terms of our methods, we did a descriptive qualitative study and recruited purposefully 18 primary care leaders from across Ontario. They were located in rural, mid-sized, and urban communities in the north, southwest, east, and central parts of the province, 10 females and 8 males, and their average age was 52. We conducted individual in-depth interviews using a semi-structured interview guide, and we audio recorded and transcribed verbatim those interviews. In terms of findings, this overview slide indicates that we sort of broke our themes into 3 for this particular study: strategies to engage family physicians in healthcare system change, the barriers to engaging the physicians, and also this somewhat surprising theme around creating a collective of family physicians. So the first set of strategies involved making contact with physicians, and these included things like town halls, email blasts, going door to door, and doctor to doctor. As one participant stated, we had a town hall and then an education session, and then they went to the one-on-one knocking on doors. And then those that still needed to be engaged would get detailing. One participant noted a mass email that's been really essential. And this next quote is kind of telling. It's hard to sustain that engagement, and we're very careful because we don't also want to push out too much information that we now become junk mail in their email. Also, there's a lot of outreach activities that have to happen, knocking on doors as an engagement strategy as an example. And another participant stated, I think it really is colleague to colleague that is most effective. The strategies I've just mentioned seem to create trust, offer respect, and help physicians to feel heard. And another participant stated, I think we need to do a lot of listening. They haven't been heard before. They've been very isolated. So let's listen. Let's form a relationship. Let's build trust. As one participant stated, this whole process will fail if we don't have trust across organizations in the OHT. It is a core element. Change happens at the speed of trust, and indeed that feeling of seeing yourself in it, seeing you're a trusted leader, creating trust with other partners. So engagement that isn't just a tick box, it's back and forth that builds trust. In terms of listening, if they feel that their voice matters, that it actually has traction, that it leads somewhere, that is the most powerful incentive. And also the way that you're going to continue to build momentum towards engagement is the fact that, number one, they feel like their voices are being heard and listened to, and it's actually affecting change. In terms of the quadruple aim, the value for patients and value for physicians in particular, this quote states, so once we've established we all want the same goals, which is to improve access and improve care for our patients, and also improve the experience for the healthcare providers, then people are more likely to say, okay, how can I help? People always ask the question, what's in it for me and what's in it for my patients? So unless those 2 questions are addressed by the OHT, I think they'll have a very difficult time getting people to buy in. And I think that the kryptonite in terms of the change and what's catalyzing the change is the patient and caregiver experience. That's the key piece. In terms of the barriers to engaging family physicians, we discovered a number of logistical issues, including remuneration and time. This is a long quote, so I'm not going to go there today since we're rushing on time. However, in terms of remuneration, we want physician engagement to co-design in the process. We've got to pay for that, and we can't get it for free. In terms of time, participants often express time and money together as barriers, as this quote illustrates. I think people are worried about how much time this is going to demand of family doctors, and how are we going to be remunerated for that? And like, what is the expectation here for us being a leader? And if you really want to represent the average family doctor, you're going to have to pay. Somebody needs to cover their practice for them to come to the meeting, right? And you can't have all your meetings at 2 o'clock. Now, some participants also offered ways to address time and money barriers, as the next quote reflects. I would say giving them opportunities to participate and appreciating their time enough to give them money to do that. There's also some issues around the impact of change fatigue. There is growing burnout and exhaustion in primary care. At the same time, you've probably got the biggest transformational change in healthcare ever. I see myself thinking about retirement regularly, but also recognizing a big opportunity for change. Maybe this is going to make a difference, and maybe if I get involved, the difference could be meaningful to me. In terms of creating a collective of family physicians, this quote sums it up nicely. A community practice is more powerful than individual voices. It's not a bad idea to bring all these practice models together in local geography. And then the other thing is that there's potential to shape the future, right? Coming together is the best way to represent a unified physician voice. community of practice that's formed organically is going to become a very powerful driver of change. And we've had conversations in our primary care community that we haven't had in 20 years. Frankly, we're further ahead than we've ever been. So in conclusion, while there are barriers to meaningful engagement for family physicians, there are a number of promising strategies to enhance that engagement, and these continue to evolve. And the two key findings, the transformative aspects of engagement to realize the quadruple aim and the development of primary care collaboratives warrants further investigation. And we're undergoing that at the moment. And so I'm very happy to have had the chance to present to you. Thank you very much.
Thanks, Cathy. It's Ron again here, just for time. I think if we can we'll just jump to the next presentation, if that's okay.
Yep.
Okay, sounds good. Sarah, if you're there, you just let me know when to change slides, okay? Sarah, are you still there?
I'm here. Can you hear me?
Yep, and
can you see my slides at all?
Yes, we can see you and
You
your
can?
slide.
Okay, excellent. Okay, great. I'm going to get going. Thanks very much for the opportunity to present at Trillium. I'm a family practice anesthetist and the workforce planning theme lead at the Canadian Health Workforce Network. And in 2016, my colleagues and I partnered, which was then with what was then the Toronto Central Local Health Integration Network, to develop a toolkit to support integrated primary care workforce planning in the region. Since that time, as a result of health system transformation, the Toronto Central LHIN has become the Toronto region, and the project has expanded to encompass all of the City of Toronto. This project stemmed from a need to address disparities in access to integrated primary care across the City of Toronto. When we first started consulting with stakeholders, we heard in every single conversation that equity was a top of mind concern. Everyone wants to allocate resources to those who need them most, but it's not always clear how to make this happen. We know, both as researchers and as patients ourselves, that the way we experience the health system is through the health workforce. And so, ensuring sufficiency of the primary care health workforce is foundational to ensuring that patients get equitable access to primary care. Back in 2016, the Toronto Central LHIN realized that the goals of their primary care strategy, which were improved service integration, system efficiency, and patient access to care, would be hard to achieve without some degree of focus on planning. They wanted any planning done to be population needs-based and evidence-informed. They also wanted it to be integrated, including all the providers and services involved in the delivery. They wanted any planning delivery, and they wanted it to address certain challenges specific to Toronto, such as patient mobility, population growth, and anticipated physician retirement. Since 2016, we've been working with the Toronto region to make integrated primary care workforce planning a reality. The project unfolded in two phases. In phase one, which took place between 2016 and 2018, we developed a health workforce planning toolkit. To do this, we conducted a scan and assessment of leading health workforce planning practices in the Canadian context and internationally. We adapted the approach we found to the needs of the City of Toronto. We also scanned for data on population and workforce characteristics, and we developed a comprehensive fit-for-purpose quantitative planning model. In phase two, which started in 2019, we also scanned for data and is still in progress. We're implementing the planning process. We are almost finished mobilizing data to populate the quantitative model, and we're using the tools in the toolkit to guide the process and produce. And we developed a comprehensive number of outputs that will be helpful to decision makers. Both phases of the project embrace a participatory action research framework that prioritizes engagement with stakeholders and mobilization of local knowledge. We've conducted numerous consultations and developed good working relationships. In phase two, which started in 2020 in progress, our consultations at the beginning of the implementation phase resulted in a statement and a purpose that guides our activities. Our goal is to build a body of evidence around the current and projected future state of population health needs and primary care service provision at a neighborhood level. We're almost finished mobilizing data in the City of Toronto. Our workforce planning process includes horizon scanning, scenario generation, our consultations and quantitative workforce modeling. These activities inform policy analysis and decision-making. Our goal is to build a body of evidence. The process is iterative and prioritizes a 1 to 3 year planning horizon. This is in line with regional decision-making time horizons and allows for regular course correction to promote more stable alignment of health workforce supply with population health needs. The process is also interactive and engagement with local stakeholders featured prominently. Here we see the quantitative workforce planning model that is embedded in the broader planning process. It's composed of a series of modules. The modules both stand alone and interact with other components of the model. The ultimate purpose of the model is to facilitate an assessment of the alignment between population service requirements and work priority for service capacity. On the population side, the information we collected about population characteristics is summarized in the Population Health Profiles module. Information about anticipated population growth due to development is summarized in the Population Growth module. How patients move around the city to seek care is captured in the Spatial Patterns of Utilization module. And we have a module that addresses unmet need for healthcare. All of this information funnels into the Service Requirements module, which generates an estimate of population need for primary care services. On the workforce side, information about the primary care workforce, physicians, the processes, our goal to provide primary care services is summarized in the Workforce Profiles module. This information feeds into the Service Capacity module. An assessment of alignment between the estimate of service requirements and the estimate of service capacity in each neighborhood is conducted. The modeling process provides an opportunity for our workforce planning to optimize alignment by shifting services between its composed of providers in an allocation step. These activities, after allocation, and prioritize a final gap. This gap is the one that informs policy and decision making, either directly or through the health scenario analysis. The end allows for regular course correction and engagements to the planning process are numerous. Because we're still validating some of the data that go into the quantitative model, final assessment. Here we see the quantities of modules, service requirements, and workforce available. But using the data sets we have assembled for the planning model, we conducted a series of descriptive on the population side, the information population characteristics of stakeholders. I'm going to show you some of these today. A good example of one of the descriptive analysis outputs is the neighborhood level census. All of this information, this is a one-page output, brings together information from multiple modules in the planning model. Which are key to primary care workforce planning in Toronto. This map, for example, looks at where patients seek their care and shows nicely that patients living on the edges of the city are more likely to patient feeds into the service of seek care outside the city, while those living centrally, assessment of alignment between tend to receive care inside the city. Maps such as these provide a starting point for understanding and modeling patient flow and spatial patterns of utilization. Our planning process makes extensive use of scenario analysis. Scenario modeling process provides an opportunity to optimize alignment by shifting services. Analysis in health workforce planning allows health system stakeholders to ask, what if? By the difference between service requirements as decision makers can consider and adopt policies that accommodate a range of possible futures. To facilitate scenario analysis, we have developed an interactive gap as the one that informs policy dashboard that allows users to explore the impact of population growth on the need for primary care services in the City of Toronto, while taking into account scenarios related to the population characteristics and workforce service capacity. The dashboard allows for up to 40 different scenarios, as we're still validating some of the data that go into the scenarios to be considered. Today, I've shared with you our approach to integrated primary care workforce planning in the City of Toronto. On the workforce side, as we've done in some of the early outputs, and you also had a glimpse of what is yet to come. This is an innovative approach to planning that is grounded in best practice and best data. By addressing specific regional planning challenges, we acknowledge the unique reality of the local health system. A good example of one descriptive analysis, we provide the best possible support to decision makers. Our approach prioritizes engagement with system stakeholders and builds local health workforce planning capacity. Our hope is a one-page output that brings together information that this approach to planning will help to promote equitable distribution of resources and a stable and sustainable primary care workforce. This is how to reach me. If we don't have time for questions, please email me.